This presentation is about diabetes mellitus type 2 in children. Diabetes is one of the most common chronic conditions in children. It is affecting over 200,000 children in the U.S., and 10.5% of these children have type 2. It was once called adult-onset diabetes or non-insulin-dependent diabetes mellitus. However, the strikingly increasing rates in children are changing the face and prognosis of such disease. In a healthy individual, digestion creates glucose, and insulin from the pancreas meets this glucose in the blood. They are then transferred into the cells where energy is created. Type 2 diabetes is characterized by slow, progressive resistance of insulin at the cellular level. This creates a cycle of elevated levels of insulin in the bloodstream. As insulin levels rise in the bloodstream, glucose is unable to enter the cells, resulting in elevated levels of blood glucose and less energy for cellular processes. The continued elevation in glucose results in a greater demand of insulin that the pancreas cannot adapt to. This creates the continuous cycle of hyperglycemia. It is important to differentiate type 2 diabetes from type 1, as there's no destruction of pancreatic beta cells, but a progressively ineffectiveness of these cells. Risk factors associated in the child population for type 2 diabetes mellitus include: being overweight or obese is known as the greatest risk factor, a BMI greater than the 85th percentile, or a weight for height ratio greater than 120%. Family history is also a risk factor. It can be because of a relative having diabetes, or it can be because of social or cultural cues from non-biological family. Being female is a risk factor because of hormones and belly fat. But being an adolescent is a risk factor because of a physiological state of insulin resistance. Race and ethnicity are also risk factors. Minority groups have higher rates of diabetes type 2, specifically American Indians, Asian Pacific, and African Americans. Associations with type 2 diabetes have been found for children who were born to mothers with gestational diabetes and women with polycystic ovarian syndrome. There are notable physical signs and symptoms associated with type 2 diabetes in children. Polydipsia is excessive thirst. Polyuria includes bedwetting, and acanthosis nigricans is particularly noted at the neck. Screening is appropriate when a child is overweight at 10 years of age, a BMI greater than the 85th percentile, being overweight with 2 risk factors, or clinical judgment. Other potential causes need to be considered, including diabetes mellitus type 1, maturity-onset diabetes of youth, and drug-induced diabetes. Diagnostic testing for type 2 diabetes mellitus. Probable diagnosis can be made on a non-fasting glucose greater than 200, a fasting glucose greater than 125, or a hemoglobin A1C of 6.5% or greater. Further testing should include a urine test for ketones and spillover glucose, a lipid panel, and thyroid-stimulating hormone for hypo or hyperthyroidism. With the diagnosis of type 2 diabetes mellitus, management strategies must be utilized. Initial management strategies focus on lifestyle change, including diet and exercise for healthy living, and daily point-of-care blood testing is essential at this time as well. Point-of-care blood glucose testing. Patients and family members need to be educated on proper ranges, as well as recording daily glucose levels and bringing them in for follow-up. Patients and families should be educated on signs and symptoms of hyperglycemia and hypoglycemia, particularly when medications are used to adjust blood glucose levels. Medication use is only considered after lifestyle change has shown to be ineffective, and currently metformin is the only oral drug approved by the FDA for use in children. Follow-up needs to be made every 3 months with uncontrolled diabetes, every 6 months with controlled diabetes, and a referral needs to be made for severe diabetes. Complications that need to be monitored for is uncontrolled blood glucose that needs a referral, and diabetic ketoacidosis, which is an emergency and requires insulin therapy. The ultimate goals of therapy is to decrease and control blood glucose levels, to decrease the BMI, and to reduce or eliminate medications. To recap, diabetes type 2 is a growing problem in the U.S. children population and causes a cycle of insulin resistance. Risk factors are important to recognize in children. Also remember that a high BMI is the greatest indicator of risk. Initial treatment should focus on lifestyle change, and metformin is the only FDA-approved oral medication for children. Thank you for watching this video.